All right, I think we will go ahead and get started because we have a pretty packed schedule. So Thoai, if you want to start us off.
Thank you, Jessie. Hello, everybody. It is my great pleasure to welcome our dear colleagues and friends around the world to this webinar on urban disparities in sexual and reproductive health and rights. My name is Thoai No. I'm the Vice President of Social and Behavioral Science at Population Council. I'm joined here by my colleague, Jessie Pinchoff, who leads our Population, Environmental Risk, and Climate Crisis Initiative, which generates ideas and conduct research on sustainable and equitable solutions to pursue justice in the face of climate and environmental change. She will share the latest evidence on urban disparity in SRHR from the Council and moderate our wonderful session today. So the Council have a history in analyzing how mega trends like urbanization, migration, climate change are shaping lives around the world and develops and tests equitable solutions to address these issues. In that light, we are pursuing 4 interconnected strategic goals through 2030, aligned with the Sustainable Development Goals, and they are ensuring sexual and reproductive health, rights and choices for all, empower adolescent and young people to reach their full potential, achieve gender equality and equity, and pursue justice in the face of climate and environmental change. And these goals are designed to address mega trends like urbanization and migration, technological advancements, really trying to address the social and injustice inequity around the world. And in order to reach these ambitious goals, it requires multidisciplinary collaboration and partnership to address the most pressing health and development challenge. We are excited today to bring together SRHR and urbanization experts to discuss the intersection across a mega trend and a health area of focus. So I want to thank Caroline, Robert, and Mukesh for your participation today. And Jessie will introduce you and the session momentarily. So as we are holding this event on the sideline of the United Nations General Assembly, I want to know that improving sexual and reproductive health and rights in urban settings require coordinated action to tackle multiple sustainable development goals all at once. And to achieve the SDG, the SRHR sector needs to adapt our research and programming to the increasingly urbanized world. And to lift up all urban residents, it is critical, in my view, that we use an intersectional approach and to promote inclusive urbanization strategy to proactively addressing inequity. To ground today's conversation, I want to share a few key trends for us to consider as we move forward in our conversation today. By 2050, over 60% of the world population will live in urban areas, and they will be disproportionately young. In cities, women and girls face gender-specific challenges related to safety, such as violence, income inequality, and persistent harmful gender norms, such as early marriage and early pregnancies. There are also geographic variations. By 2050, some of the world's largest megacity will be in Bangladesh, the DRC, Egypt, and Mexico, and among others. But the research publication and programming on urban SRHR are disproportionately located in Kenya, Nigeria, and India, where major development investment have been made. So we need a diverse set of evidence in different settings and a shared language for the urban landscape and how it presents structural barriers to addressing SRHR. City are economic powerhouse. We all know that, but without urban planning and inclusive policy, we might see progress to stall. Recent estimates suggest that young people living in urban centers are 4 times more likely to be unemployed than adults. And indicators are worse for women, including lower salary, more informal sector work, and more time in unpaid domestic labor, which inhibited for reaching gender equality and equity in urban setting. So ensuring SRHR needs are met is one critical building block for women and girls to participate in a much more inclusive urban life. I'll now turn over to my colleague Jessie to lead us through the current body of evidence on urban SRHR disparity. Thank you very much.
All right, thank you. So as Thoai noted, the world is rapidly urbanizing, and generally urban residents are found to have better health indicators, longer life expectancy even than their rural counterparts. And this is due to a variety of factors, in large part better infrastructure, availability of a higher density and variety of health service providers. But we know that these resources and advantages are not equitably available, and slums or informal settlements within cities can be highly isolated with gaps in public sector service coverage and experience of much worse health outcomes compared to other urban areas, and even worse than those in rural areas. So if these stark disparities are not addressed, they will continue to grow. Our latest findings suggest that the evidence base sort of is lacking a robust discussion of how features of the urban environment and other structural factors like social and economic inequality can contribute to and reinforce cycles of poor SRHR outcomes. And this includes a few things that Thoai mentioned: physical safety. The majority of women residing in slums in different settings report experiencing everything from sort of street harassment to intimate partner violence. Housing insecurity and crowding. Slums may have really high eviction rates with very little notice and very little recourse, or people may live with a lot of roommates, and this can lead to sort of unsafe conditions and potentially increase the risk of transactional sex to try to create some stability. Other factors such as unaffordable transportation that can force decisions to maybe forego health services or result in options to travel longer distances for maybe free healthcare or going somewhere local where often the services and products are actually more expensive and may be of varied quality. So we recently conducted an evidence review on urban SRHR challenges and found over 3/4 of the articles that we identified focus mostly on individual level risk factors of urban residents like age or marital status, and less so on addressing these structural barriers and how they may interplay to create these outcomes. So despite the many aspects of comprehensive SRHR, we also found that literature in urban areas tends to concentrate on topics like family planning and HIV, and there's much fewer studies reporting on topics like gender-based violence or abortion provision. There are some interventions and programs that are increasingly being evaluated and reported on to improve the SRHR of urban residents. Some major ones, the Urban Reproductive Health Initiative that tests facility-based interventions, supply-side interventions, provider training programs that have seen some positive results. And then there are also some programs attempting more of a holistic approach. Two examples coming out of the council are Biru Tesfa in Ethiopia and the Adolescent Girls Initiative in Kenya, that aim to address really the root causes of SRHR with a focus on adolescents by triangulating their needs with these multi-pronged programs that build in social capital through safe spaces for girls, a violence prevention component, health education. And in Kenya, there was also a conditional cash transfer for attending schooling. And these had some positive outcomes on knowledge regarding HIV and uptake of certain services. So we'll be hearing more about some of the work that's been going on this topic and on working with urban populations in a moment. So to improve SRHR for urban residents moving forward, we have some recommendations, and again, we'll discuss them more today, but these include improving measurement to allow us to make intra and inter-urban comparisons to address some of these structural determinants, to take steps to include all perspectives, including the most marginalized subpopulations in cities, and at really all points throughout the process. So from research design and research questions up to surveys and then actual inclusion in some of these programs. And also the importance of working with a variety of stakeholders to design innovative programs and policies, and really taking the opportunity to leverage the urban environment and the opportunities that that environment affords in solutions, for example, leveraging different types of technology or some of that connectedness. So I am now delighted to welcome our panelists, and they will be sharing their expertise, and I'm sure we will have so much to learn about their work today. We hope this session will facilitate a collaborative discussion on future directions to guide policy, research and programming investments in this important area. So I'm going to introduce our panel, and then each panelist will have about 8 minutes to discuss their work, and then we'll have a moderated question and answer followed by an open question and answer. But a quick housekeeping note, because of the large number of participants, please, if you have any questions throughout the session, put them in the Q&A box on Zoom. Our panelists may respond in real time, or we will also be pulling from those questions for the open Q&A at the end instead of having microphones going on and off. So we will read out some of these questions. And then we are also happy to share contact information if there are more questions or avenues for discussion past the end of the seminar today, since it is a bit short on time. So our first panelist, Robert Ndugwa, do you want to go ahead and share your slides? He is the head of data and analytics at UN Habitat, and he is an expert in data monitoring, statistics, and has a focus on urbanization. Thanks, Robert. Yeah, if you swap, that will work. Great, thank you.
Thanks a lot, Jessie, for that warm introduction, as well as to Population Council for the invitation to participate in this event. I'll shortly, I think, present most of the global work that we are doing, and of course, highlight the implications it has on sexual and reproductive health rights. I think to set the background, I just wanted again to pull up perhaps part of the context that each one of you has referred to very well. And today we are living in a very urbanized world, but also one that is also urbanizing very fast. We can see this in a variety of statistics. For example, just from the number of cities with population over 1 million, this figure was around 584 in 2018. And of course, this is expected to be around 706 by 2030. And the message here is that while we are urbanizing very fast, we need to enhance the opportunities that are also available to ensure that we get this urbanization right. And that's the only way we'll be able to reap the dividends that comes out of the urbanization that we are facing. But from the side of UN Habitat, what we also see is that we do have two global agendas running almost concurrently. That's the New Urban Agenda and the SDGs. And these have already taken note of the intersectoral, but also the interlinkages that exist across a variety of dimensions. And here this ranges from the aspects of better urban governance, the aspects of the sustainability on the environment, the equity and social inclusion, as you referred to in your introductory session, but also the aspect of quality of life, or how productive our urban areas are, but also the infrastructure that is available. And I will connect these very much to where we see the links with the sexual and reproductive health rights. But on the other hand, when you look at this from the point of the people perspective, it tends to come through very much in terms of the culture endowment we see in the urban areas, or the young people, or the aspects of gender, or the human rights in general, but also recently the aspect of health and the element of inequalities and the poverty we see in urban areas comes into play. So literally for many urban city leaders, they tend not to look at these things in sectoral angles, but they want some sort of a holistic picture of how do we really get these pieces right in a way that a city is prosperous for everyone that lives in such a city. So when you look at some of the urban trends that comes from our data sets, taking the example of Africa on its own, we see first it's a very urbanizing world, just like any other part of the world. But there are a few unique dimensions that need to be taken care of here. For example, in many African countries, we are seeing almost a change, almost 5 to 10% shifts in terms of urban populations. Here, taking the example of 2000 to 2016 as a set of the window before the SDGs came into play. That was the era of the MDGs. We see that quite a number of African populations have changed, sometimes by 10% differences, 15% differences, and there are real substantive implications here when we analyze to try and understand who exactly is actually being left behind. And what we notice in many cities, particularly those in the developing world, is that urbanization is happening, but it's happening at a very much lower level of incomes. And here, just taking the example of Lagos and Paris, 2015, again, as the reference here for the change from MDGs to SDGs, we see that while the population of Lagos was 11.4 million, Paris was 11.2. But when you look at the aspect of their city GDPs, you see significant differences and big margins. And of course, here, the whole idea is how can we, for example, get our urbanization right in a way that it also matches the prosperity of the people living in many of our cities, particularly in the developing world. And I think on the side of other services, sometimes what we forget is that sexual and reproductive health rights don't come, particularly in urban areas, such services don't come alone. They tend to come as part of a package. Either it comes because of a good education system, it might be because of a good functional transport system, or many other aspects. And here, just examining some of accesses of these services in urban areas will somehow give you an idea of who exactly is being left behind. I think as Thoai and yourself noted, Jessie, in the introductory remarks, that the tendency, particularly in these urban areas, is that the same populations that are lacking sexual and reproductive health rights, or those that are being left behind, tend to be the very same ones that are lagging behind on all other services. For example, housing, when we look at the population of the urban population who live in slums, these are global numbers, but it shows you that this problem is now very much a problem of Central Asia and Southern Asia, and largely Sub-Saharan Africa. So this is where the populations are actually being left behind. And sometimes when you replace the aspect of just housing and slums with some of the other indicators, you tend to see that, again, it's these same populations. And the question is always, why is it always the same population? And that's what we need, I think, to begin answering at the end of this sort of conversation. When you take a look as well on another angle, perhaps on water, populations with access to improved water sources, or even diving a little bit deeper to look at just a special prime sort of service, piped water, just access to piped water, because that's very essential in urban areas. Here, what we've tried to dissect is to look at urban as a whole, rural as a whole, but also look at capital cities versus other towns, or even slum versus non-slum. And you begin to see, for example, just Angola alone in 2006, you can see that there's a huge difference between populations during that period. For example, for capital city, access just to piped water is about 36%, but this falls down to other smaller towns. And of course, when you look at slum versus non-slum, you begin to see a big margin as well. But the message here is that sometimes we get it wrong simply because we tend to focus also on just some cities alone, but not necessarily the secondary towns, where unfortunately a lot of the urbanization is actually happening there. But if we don't get that right, sometimes what we don't also get right is the whole aspect of in urban, slum versus non-slum, how much is the difference? And here you see on just this indicator alone, the slum populations are very much being left behind. And the story is also true on many indicators, with the exception, for example, for education. Here, just pulling up an example of 5 countries, you can see that when you look at rural, urban as a whole, or slum versus non-slum, education is faring largely well for many countries, and we have this sort of data for close to 60 countries, but it's largely faring well. But perhaps for Guinea is a unique setting that in the rural areas, much of the school attendance in primary school is way lower when it comes to the rural. But on the urban side, they are comparable on a large scale without big variations. But when you take a look at attendancy by a professional attendant for giving birth, here we tend to see, for example, huge margins beginning to come through. For example, Guinea, again, the rural areas are largely lagging behind across the board for many countries, taking the case of these 4 countries. But in the urban areas, we also see some sort of margins, particularly in the urban, as well as slum versus non-slum. And the story here is, unless we get high-grade disaggregated data, we are unlikely to understand exactly where are these big averages coming in when it comes to access to these sort of services. In my view, there are many services that probably are available at the individual level and at the household level, but there are some that are available at the social level, and that is where the element of transport becomes very essential, particularly for a functioning urban area. And just by examining the indicator for the proportion of the population that have access to convenient transport in cities, you see that from the global average, that sits to about 50%. But of course, for those who have areas that are serviced by public transport, it drops down to around 37.2. But when you come to a continent, for example, like Sub-Saharan African region, these numbers come down to 30 or 31% for convenient access to public transport, while the serviced areas are less than a quarter of that. And this is when you begin to ask the question, when we see, for example, the performance of sexual and reproductive health not coming through, sometimes those are social services. Somebody needs to move from point A to B to access such services. And the implication might be that we need to shift these sort of numbers to shift the numbers on the side of the sexual and reproductive health. So for us, this is where it all comes down to, how do we holistically balance up all these essential services in urban areas in a way that it actually offers prosperity as a whole? And the package, in our view, is that it lies into well-designed national urban policies or regional development plans, which in a way should be able to address the aspects of what we see in the population dynamics. It should address the balancing of the territorial development, particularly between urban and rural, but also within urban, who exactly is being left behind. That territorial development becomes important. And of course, the financing part is equally very essential. When you look on the board, there are quite a number of countries that at different stages of developing these national urban policies. And of course, part of the challenge has been some develop them, but they never implement them in a way that it actually delivers these sort of results. So my take-home message, I think, for the audience today is to understand that, yes, all these rights, all these services are very important, but unless we have a glue that joins them together, we are unlikely to achieve a lot of the targets we've set out in the SDGs, including those in the new urban agenda. Thank you.
All right, thank you so much. Our next speaker, Caroline. So Caroline is a senior researcher at the African Population Health Research Center, or APHRC. She is an expert in SRHR in Sub-Saharan Africa and has led some initiative focused on adolescent health. So thanks.
Thanks, Jessie, and thanks to the Population Council for the invitation to join this very important discussion. My presentation is based on a scoping review of 54 studies on adolescent sexual and reproductive health in urban slums in Sub-Saharan Africa that was conducted in 2020 by my co-authors, who are acknowledged here. The scoping review is published in the BMC Reproductive Health Journal and is available open access, and I'm happy to share the link later. So, why did we focus on urban poor adolescents? I think as Robert has highlighted in his presentation, Africa is one of the fastest urbanizing region, and as a result, a lot of there will be a rapid growth in the adolescent population. And through the estimates from UN Habitat and UNICEF speak to more than half of children and youth in Sub-Saharan Africa in 2050 living in urban areas than in rural areas. And again, just stemming from the presentation that Robert has just made, majority of these young people will be growing up in contexts that are marked by significant deprivation and with potential impact on their sexual and reproductive health. And Jessie spoke about some of the links between growing up in poverty and how that might affect sexual and reproductive health outcomes. So in terms of the scoping review, it covered 54 peer-reviewed manuscripts and reports that were published online in English between January of 2000 and May of 2019. We included studies that included a focus on adolescents, 10 to 19, who were living in urban slums, or informal settlements, inner city or deprived urban neighborhoods in sub-Saharan Africa. And we included studies that described sexual and reproductive health behaviors and outcomes. And that spanned from sexual behavior all the way to specific outcomes that are that sexual and reproductive health and rights outcomes. So what did we find? I highlight 4 areas in terms of key findings, and the first 2 are: 1, there has been a steady growth in research on adolescent sexual and reproductive health in urban slums. But when you look at the research that is published, it's actually of very limited geographical scope. And I think Thoai spoke about this in his remarks. Much of the research was focused on East and Southern Africa. Of the studies that were published, there were very few multi-site studies that would allow comparison between cities in different countries, or even within a country, looking at different cities. There were very few qualitative and mixed method studies. So many of the studies were observational, cross-sectional, quantitative surveys among adolescents. And they had a very limited focus on intra-slum inequalities. And Robert has spoken about the value of some of these comparisons as we're thinking about research on SRH in urban areas. Majority of the papers, 2 in 5, were really looking at sexual risk behaviors, and much of this is within a context of high HIV prevalence and, of course, high levels of unintended pregnancy or early pregnancies. And so, yes, it does make sense that there is quite a bit of focus on sexual risk behaviors, and many of those studies speak to the higher prevalence of sexual risk behavior among young people living in urban slums compared to their counterparts who are living in non-slum areas. And in the discussion, although a lot of the data was collected at individual level, in terms of the analysis and in terms of the discussions, they really speak to behaviors being driven by individual relationships, social and structural factors. There was when we're looking at sexual and reproductive health in outcomes, the focus was quite limited. As I mentioned, a greater focus on pregnancy and HIV and AIDS, which does make sense given the prevalence of HIV and AIDS and especially the vulnerability of girls in this context, as well as pregnancy. And we see less focus on sexual and gender-based violence. And Jessie had spoken to this in her opening remarks about how urban slums can really create an environment where people are at increased risk of sexual and gender-based violence, but yet you don't see that reflected in the research. And then in addition, there's very limited research on sexually transmitted infections, with the exception, of course, of HIV, and limited research on abortion in adolescents. As Jessie noted, there are studies that look at interventions, but those are really the minorities of the studies. Only 15% of papers reported on intervention studies. Again, the scope was quite limited, mostly centered on Eastern Africa, and even within Eastern Africa, we can say many of them were focused on Kenya. And they primarily address the socioeconomic correlates of poor adolescent sexual and reproductive health outcomes. And so, as Jessie mentioned, the Population Council has done some work around cash transfers. And then there was quite a number of the intervention studies were looking at imparting sexual and reproductive health information, and as well as giving life skills education to young people. So in sort of pulling all this together and sharing some reflections on what the implications are for research as we move along. First is more related to the types of studies that we conduct, and then the scope of the research that we conduct. So as I mentioned, most of the studies that we came across were cross-sectional studies, mostly quantitative. But I think as we think about being able to elucidate pathways between risk and protective factors, sexual behaviors, and sexual and reproductive health outcomes, longitudinal studies have a place. And I know the Population Council has done excellent work with adolescent cohorts that really informs a lot of our knowledge about these pathways. Again, qualitative studies, especially that explore cultural norms and contextual characteristics are critical, and studies that examine intra-slum inequalities, but also maybe I'll add now, given what Robert spoke to, also looking at variations between slums in one city, but also across different cities, and also thinking about the secondary cities that Robert highlighted. In terms of scope, there is a need to expand the scope to include outcomes outside of HIV and pregnancy, sexual and gender-based violence, sexually transmitted infections. When Robert spoke, he did present data on skilled birth attendants, and we know very little about adolescent girls' experience with some of these services. So it's also important to also look at maternal health among adolescents and abortion. I think in the framing of research on adolescent sexual and reproductive health, much of it is actually focused on sexual risk behaviors, but I think there's also a need to expand the framing to look at positive aspects of sexuality. And finally, in terms of the intervention studies, I think there's already, you sort of feel like, yes, there is that recognition that we need to create an enabling environment for adolescent sexual and reproductive health. But when you look at the interventions, they're very individual focused at the adolescents. Yet that enabling environment includes making sure that parents are equipped with information to guide their adolescents. Healthcare providers need the training around provision of youth-friendly services, or services that are responsive to the needs of adolescents. And we know that even in urban areas, majority of young people are in schools, and we need to make sure that school provides that enabling environment. So I'd really like to end these brief remarks by acknowledging the support from the David and Lucille Packard Foundation for the scoping review, and also funding from the Swedish International Development Cooperation Agency. And I just thank everyone for your attention, and looking forward to the rest of the discussion. Thank you.
Thank you so much, Caroline. And now our last speaker, I will go ahead and share the slides. Okay, our last panelist, Mukesh Kumar Sharma, who's the director of PSI in India. He is an urban health and reproductive health specialist, and he has extensive experience on programming and knowledge management for various projects in India. So please go ahead. Thank you.
Thank you, Jessie, Caroline, and Robert. And thanks to Population Council for organizing such a very important webinar on very important topic. So welcome to all of you again. And before I initiate the slides, I have a small request to all of you. Keep two things in back of mind during this presentation and discussion. So number one is an unmarried adolescent boy or girl who is having many life skill questions, including health questions, and that to be with contraceptive included. And number two is a first-time parent who want to space between a recent and next child and what options they have in their mind. So keep these two characters in mind, and let's discuss some of the points in my presentation. Next slide, please. So this is very interesting slides and and I believe that Robert and other presenter mentioned about this. But it's very important to understand that how the demographic dividend looks like in our country, India. It says that why adolescent and their health is important and non-negotiable. So countries having 66% population who are below 35 years of age, and 41% population is under 20 years of age. So adolescent is very critical and important considering health and especially family planning and contraception. So perhaps a great demographic dividend to have a healthy and young country. Next slide, please. So the second important thing is rapid urbanization, and we have seen the Robert's presentation and the data, the global data. So urbanization is very rapid in countries, and in India, it's quite visible. And with this urbanization, the urban vulnerable population is also increasing. And when we talk about vulnerable population, we talk about slums, and different types of slums are present in the country, and we call it listed slums, who are listed in government authorities and municipal corporation. Then we have unlisted slums. We have unregistered and unaccounted slums. We have unauthorized slums. And there are many more categories. Why this is important? Because health for all is commitment with concept of universal health coverage. And as urbanization is rapid, the urban young population is also increasing significantly. And we have to keep this in mind when we are talking about universal health coverage. Next slide, please. So it's very important that whose responsibility is to ensure that adolescent boys and girls and first-time parents receive their desired health services, including contraceptive and family planning services. It should not be the sole responsibility of one organization or only government. But yes, government focus, investment and policies are very important to ensure that family planning and contraceptive services are available for this young population. So in country India, we have a national family planning and contraceptive program, perhaps oldest in the world. And we have a national adolescent health program where policy suggests that how we can provide life skill education, including contraceptive knowledge and information to unmarried boys and girls. Family planning services and contraceptive services are included in all the service delivery points in government and private sector. And private sector involvement through public-private partnership mechanism and strategic purchase of the services for the poor is tested and proved in many of the states of the country. That is also very important to understand what is the situation in terms of policies in country. Next, please. So the important is what was required to support implementation at a scale. So to understand the practice, behavior challenges of the unmarried boys and girls and first-time parents, PSI India under the Challenge Initiative program did two types of surveys and research. One is formative research with unmarried boys and girls, and second one was 2 rounds of output tracking survey, and first-time parents were included to see the contraceptive prevalence rate among first-time parents and what challenges they face. So these two research and surveys helped us to design the strategy and help government to design the strategies. Next, please. So a methodology we used for formative research is we selected 2 cities, Firozabad and Varanasi in Uttar Pradesh in India. And we had focus group discussion and one-on-one interviews, in-depth interviews, and some field observations. So the target group were unmarried women 15 to 24 years of age, unmarried men 15 to 24 years of age, then currently married women 15 to 24 years of age, and currently married men 15 to 24 years of age. And we had multiple fixed focus group discussions and in-depth interviews among these categories of target group. And based on that data, we have analyzed the findings. Next, please. So now coming to the output tracking survey, which was the population survey, and it happened 2 rounds, 2018 and 2019, exactly after 1 year of gap. And it was a cross-sectional design with multi-stage random sampling. And it was a household survey, covered women of 15 to 24 year of age, and that included first-time parents. And sample size was estimated to detect if there is change in modern contraceptive prevalence rate and what is the change rate. And data collection was done, as I mentioned, in 2018 and 19, and especially in 5 EY/SRH supported cities of Uttar Pradesh. So overall, in both the rounds, around 8,000 respondents were covered to see the results. Next, please. So jumping to the results. So so far as first-time parents and contraceptive uptake among first-time parents, it was clearly visible in the cities where TCI projects supported. And I mean, we can see that 38.5% of first-time parents were using contraceptive method in comparison to non-supported cities where the use was 31.9% among first-time parents. So and at the same time, their reach to the contraceptive information also increased significantly. And in supported cities, the information reached to 50.6% of first-time parents, comparing 32.4% of first-time parents in non-supported cities in India. Next, please. So considering time, I'm focusing now on the formative research, especially the barriers for uses of contraceptives among boys. So through our focused group discussion and in-depth interviews, there are certain critical points came out through formative research, which helped us to design the strategies of the project and supporting government to design their strategies. Number one was lack of correct knowledge on contraceptive methods among unmarried boys. And their belief on withdrawal method as very effective contraceptive method. Because their sex is not planned, always not planned, and they believe that withdrawal can work well. They also reported that pharmacists in the urban areas generally refuse to provide methods to unmarried boys, and that was a big barrier to use the contraceptive method if required. And many of them, because of technology is very much there in hand of unmarried boys. So searching internet and alternative for contraception on internet is very common among them, and many times it's approved information, many times it's unapproved information they are receiving. The one more thing they've mentioned about easy access to abortion pills. They strongly believe that if something goes without contraception and they do the intercourse, then abortion pills are available over the counter, and that can save the girl from unwanted pregnancy. And next one is lack of designated space to store unused contraceptive, especially condoms. So for unmarried boys, if they have either they have to purchase the condom every time from the shop, or they are facing the problem of a designated space to keep the contraceptive safe. Sex is already, I mentioned they mentioned that sex is mostly unplanned. So many of the times it becomes a big barrier, and they have some information and negative experience from the friends around contraceptive, especially condom was reported, that how to use, where to dispose, when it has to put on, and all these things came up. Next, please. So in my last slide, barriers for users of contraceptive among girls, there are 4 or 5 very critical points came up. The number one, again, is a lack of correct knowledge on contraceptive methods. They have no correct knowledge about the methods and their availability. And they have reported that they have a significant mistrust on contraceptives such as pills. So that mistrust is there because of lack of information. They have very limited social network to seek information because they are surrounded by the family members with very less numbers of friends and peers in the communities, and lack of self-efficacy to go and buy contraception. So girls reported that it's very difficult for them to even go to a pharmacy to purchase a condom or pill if required. And the last point is very important, and it came in most of the individual interviews and FGDs, that lack of self-efficacy to negotiate with partner for a use of condom. So that negotiation skill, negotiation capacity is also very much on the lower side. So these are the findings from urban areas and especially from urban poor population. And that guides us to have a comprehensive family planning and contraceptive products and service delivery mechanism plan in place in government leadership and with private sector participation. We have to keep in mind that I mentioned in the beginning, please keep 2 persons in mind. And we have to keep in mind that none of the unmarried boy or girl and none of the first-time parent should have unanswered questions on contraception based on their need. This way, the urban disparity in SRHR services can be resolved, or we can move towards resolving those issues which are prevalent. So thank you all very much for listening this presentation, and we are open for the questions. Handing over to Jessie.
Yeah, thank you so much. Everyone can feel free to put their questions into the Q&A box and we will read them out. I can kick us off with a question. I have a question for Robert. You mentioned these national urban plans, and I'm just wondering, are there any specific types of data sources, monitoring systems that you guys are working on, and sort of any best practices to sort of get the data that's needed to make some of these plans? I would love to hear more about that.
Thanks a lot, Jessie, for that question. Yes, indeed, the many national urban policies as well as development plans are very much developed from an evidence-based perspective. And that means drawing in a variety of data sources. So we usually compile data coming in from the censuses, from the demographic and health surveys or other household surveys that are available, but also other user service-based surveys, particularly coming in from the sectors, for example, in health or from transport, to complement and understand the bigger picture of what is happening in that context in any given country or city. But of recent, we've also incorporated new data sets, such as the citizen-generated data sets, to get a little bit of perspectives on what are their priorities as seen from this angle of the people, which we tend to call the people-centered approach in terms of understanding the meaning for that data. And in the same way, we've also integrated the big data and predictive analytics to try and give us on a holistic picture in any city what is happening on some aspects. For example, in air pollution, that is very important for the big data analytics. So in a way, we've integrated both official and non-official statistics for these national urban policies. And the idea is, of course, all these data pieces are important. They tell a different story. It might be from the quantitative or qualitative, but that story needs to somehow aggregate into the lives of people who live in these cities to make sense for them to prosper in such an urban setting. So we've developed some of those methodologies. They are available on our websites. For example, we now have a global urban monitoring framework, which integrates 72 core indicators that we believe need to be collected in any city or in any urban areas. They cover a variety of sectors, so they allow you in a very simple way to understand what exactly does this city look like in terms of baseline or benchmarking, and then thereafter you can track the progress over the years. And this has come through with a lot of inputs from many partners, from the cities themselves, but also from the national statistical offices, civil society, academia, to try and aggregate the stories of what people feel should be measured, and particularly what is also measurable is important, because designing a good indicator, but if it's not measurable, doesn't become very useful. So quite a number of cities are already applying some of those tools from Latin America, Asia, but also in Africa, moving particularly towards the aspect of monitoring prosperity, but both from the angle of the policymakers as well as from the citizens themselves. Over.
Thank you. I actually have one quick, there's one question in the chat, Robert, and I'm wondering, I mean, we've talked this whole session about slums and urban areas, is there a slum definition that UN Habitat is using that we should be keeping in mind, and also, any sort of unmeasured aspects to, sort of defining slum neighborhoods?
Indeed, there is one, Jessie, and thanks for that question, wherever it came from. For the UN Habitat uses a household-based slum definition. Basically, it's premised on the idea that if you live in an urban area, you need to have a certain core level of services. So water, sanitation, a level of crowding that is acceptable or probably not acceptable. And then security of tenure, basically knowing that you're safe and secure with your piece of land or household. And of course, the durability of that house unit, particularly through the aspect of the roofing or the walls or the floor. So we use that because prior to utilizing the household-based slum definition, the geospatial technologies at that time were not available for them to identify exactly which space is slum versus non-slum. So the household-based definition basically goes by the approach that if you lack any of those services and you're in an urban area, then you're considered to be sort of deprived in terms of your services that you're receiving, and therefore you're tagged as a slum household or a potentially an informal settlement household. So that's what we use, but we are transitioning from the household-based definition towards the spatial definition, where spaces are identified through geographical geospatial technologies and other observation technologies. And then after you identify that, we've developed what we call gridded populations. So we know which population lives in which grid, and so you can work out the numbers very easily for any city or country by working from the gridded population, as long as you identify which grid is actually looking like a slum versus non-slum. So the technology to identify a slum household from space is what is currently being refined, but we hope to switch over to that approach in 2024. Thank you.
Thank you so much. I have a question for Caroline. You mentioned reaching adolescents, and I'm just thinking if you could talk a little bit more about some of the challenges in reaching them. I mean, I would imagine schools offer an opportunity to reach them, but out of school, adolescents may be more challenging. And then just thinking as a researcher, depending on the age range, having to have that parental involvement potentially. So I'm just wondering what some of the challenges are to having inclusive participation from the adolescents in research and the programs that you've come across, and how you've addressed them.
Thanks, Jessie, for that question. And yes, I think with adolescents, schools provide one avenue to reach them, because we know that in many slums across sub-Saharan Africa, speaking specifically about sub-Saharan Africa, many of them are in school. But we must remember that there are also a lot of adolescents who are out of schools, and it may be a bit more challenging to reach them. And it's important to think about creatively around how to reach them. And part of that is engaging with them to find out which spaces really make sense for them. We have been doing some work on pregnant and parenting adolescents in 2 cities in Africa, Ouagadougou and Blantyre. For many of these young people, we were able to reach them at their households, and also for some, also engaging a lot with non-governmental organizations that work with young people, and they'll be able to reach out to them. Also trying to reach them through community health workers who really have presence in the community. But I think the important point is, in our research, we need to ensure that we're including a diverse population of adolescents, remembering they're not all the same. Some are more marginalized, especially like now when we think about pregnant and parenting adolescents, not in school, often probably looking for work, and therefore may not be actually available for a lot of the programming if we're thinking about something like SRH education. And in thinking about, for example, interventions for them, one also needs to think about, if they're parenting, there also has to be a child care component so that they can actually participate in the interventions that one is designing. So I think it's just in terms of being more creative in terms of how we reach out to them and making sure that we're being inclusive in how we reach adolescents.
Thank you. Yeah, those are great points. All right, and then I have a question over to Mukesh. There are some questions in the chat about the mistrust that you reported in contraceptives, and if that varied a lot by the type of contraceptive, and if there was any reason for that. And then I'm also wondering if there were any things that came up in your findings to think about sort of how to implement some of this programming in sort of a more conservative culture, and how to sort of build that in so people can use the services, you know, if they're unmarried or young. So thank you.
Yeah, so thanks, Jessie. So I believe that both the questions are related to lack of information and correct knowledge to the respondent and to the beneficiaries. So number one, which we reported, or the girls especially reported about the mistrust on the certain methods. So this mistrust is mainly coming from their peers, what they are hearing from their friends and colleagues. I mean, the peer they are living with. So they also mentioned that the right information source they are not aware of from which site or which place they should get the right information, because their access to the technology is also limited because they are unmarried girls, and mobile phones and other things are with the parents at most of the time. The second thing is how unmarried boys and girls has to use contraception if required. It's very much linked with the provision in the policy of RKSK, the National Adolescent Health Program, which talks about with the life skill education, they should also have the health education, including education on contraceptive products and requirement, and from where it can be get available. But considering the unmarried boys and girls in the society, these are not very direct kind of intervention in the communities, but it's a package of intervention which includes life skill educations and includes contraception, its availability, its needs, unwanted pregnancy, and from where it can be obtained. Apart from that, there are private sectors and government facilities available who provide it kind of counseling and services. But most of the time, especially unmarried boys and girls are not very comfortable to go to the facilities because of confidentiality issues. Private sector is still preferred by them because they believe that everything will be kept confidential if they are going to the private sector. But the, the specific strategy and plan has to be at place. For the first-time parents, if you see the data or any type of survey data in the country, you will find that modern contraceptive prevalence rate is lowest among the first-time parents, and fertility is, unmet need is highest in the first-time parents. And the family planning programs are mostly towards the sterilization driven in the country, and method mix is sometimes get marginalized in the policy and programs. So now government with the private sector and with the partners agencies focusing more on the method mix and focusing more on the first-time parents and newly married couples. And many of the initiatives have been taken by government and private sector to do that. But yes, it's important to understand that MCPR is low and unmet need is high among first-time parents, and that need to be addressed. Over.
Great. Yeah, thank you so much. Okay, it's we're at the end of our time. I just wanted to take a moment to say thank you to all of our panelists and to everyone who was able to join us today. I think, as we're heading, likely many of us, next over to ICFP, some things that we've talked about today, some recommendations to think about improving some of the measurement and data that's available to policymakers in urban settings, allowing for intra-urban comparisons either across the same city or between different cities so that we can really learn about how to contextualize some of our programs. We've highlighted the need for some multidisciplinary work in urban settings, and reaching out and working with sort of difficult to reach populations, and working with adolescents and youth, since these are issues. They're a growing proportion of the urban community, and these are critical issues to address for them. So we look forward to continuing some of these conversations and to continuing to collaborate on this work. So thanks for attending the session, and I can stick around for a couple of minutes if people have questions, but otherwise, thank you so much.